एसिडिक ड्रग्स एसिडिक मीडियम में ज़्यादा सॉल्युबल होती हैं। क्यों? वीक एसिड्स एक रिवर्सिबल रिएक्शन के थ्रू अपनी फॉर्म को चेंज कर सकते हैं डिपेंडिंग कि वो किस मीडियम के अंदर प्रेजेंट है। इन एसिडिक मीडियम हाइड्रोजन आइंस बहुत ज़्यादा होती हैं, तो वो बैकवर्ड डायरेक्शन ऑफ द रिएक्शन को फेवर करती हैं और अनचार्ज्ड फॉर्म ऑफ द एसिड इंक्रीज कर जाती है। जब अनचार्ज्ड फॉर्म इंक्रीज करती है तो बिकॉज वो ज़्यादा लिपिड सॉल्युबल होती है, वो आराम से लिपिड बायलेयर ऑफ द सेल मेम्ब्रेन्स को क्रॉस कर लेती है और वो सेल्स के अंदर, टिश्यूज़ के अंदर आराम से जल्दी एब्जॉर्ब हो जाती है।
Basic drugs are more soluble in basic medium. Why? Basic drugs can change their form depending upon the medium in which they are present. In basic medium, there is excess of hydroxyl ions. Hydrogen ion tends to combine with these hydroxyl ions to form water. So this creates a situation in which the reaction is favored in the forward direction. Hence, more uncharged form is produced, which is more lipid soluble and is readily absorbed across the cell membrane.
Volume of distribution is a hypothetical volume available in the body to contain the drug. It tells us how widely a drug distributes within the body. Drugs which are small in size, lipid soluble, or tend to bind to the intracellular proteins will have large volume of distribution because they will easily go out of the blood vessels into the surrounding tissues. Drugs which have a large size, less lipid soluble, or if they are bound to the plasma proteins, they will not be able to cross the blood vessels and go into the surrounding tissues. They will stay inside the blood and will have a small volume of distribution. Excretion is the removal of active drug or its metabolites from the body. The drug or the metabolites essentially leave the body through kidneys, GIT, lungs, or skin. Elimination is the irreversible loss of active form of the drug. This can occur either through excretion, where the drug or the metabolites leave the body, or through metabolism, where the active form of drug is converted into inactive metabolites. So elimination includes excretion as well as metabolism of the drug.
Dear students, let's see what is the difference between a full agonist, a partial agonist, an antagonist, and an inverse agonist. For this, first we need to know what is the constitutive activity. Constitutive activity means the intrinsic activity of a receptor. Our body is in a state of equilibrium, a dynamic equilibrium in which there are 50% activated receptors and 50% inactivated receptors. When a full agonist binds to the receptor, it converts all of the receptors into the activated form. 100% activation resulting in maximum stimulation of the receptor. For example, the normal heart rate in our body is 60 to 100. This is the constitutive activity, a dynamic state that is maintained by the constitutive activity of the receptor. Binding of a full agonist results in conversion of all the receptors into the activated form, resulting in tachycardia, heart rate that is greater than 100. A partial agonist will convert some of the receptors into the activated form, but the overall number and the overall effect will be lesser as compared to the full agonist. An antagonist will equally bind to the activated state and the inactivated state. However, it will not stimulate any of them and prevent the binding of an agonist Therefore, there will be no increase or decrease in the response. It will just stay the same. In the case of heart rate, the heart rate will stay the same in the range of 60 to 100. An inverse agonist binds to and increases the inactivated state of the receptor and decreases the activity into the opposite direction. It goes against the constitutive activity. In this case, the heart rate will fall below 60 beats per minute. I hope that clarifies the concept of agonist and antagonist. Spare receptors. Spare receptors are the excess number of receptors which remain unoccupied even when the maximum response has been produced. Two values are important. One is EC50, which is the dose at which 50% of the response is produced. The other is KD, which is the dose at which 50% of the receptors are occupied. In a system with spare receptors, EC50 is always less than KD, which means that the dose at which the 100% response is achieved is lesser than the dose at which the 100% receptors are occupied. You see, the dose that produces 100% of the response, at that dose, the number of receptors occupied are less than 100. So that means for a system to have spare receptors, EC50 should be less than KD, or if we turn it around, KD should always be higher than the EC50. Hope that clarifies your concept. Comment for any queries or questions. Thank you.
Oral route of drug administration refers to administration of drug through the mouth and absorption through the alimentary canal to enter the systemic circulation for some distant target of action. Oral route has certain advantages such as it is convenient, economical, widely acceptable, and no skilled personnel is required. The disadvantages include first pass effect, which is the pre-systemic metabolism of the drug. It cannot be given in comatose patients, unconscious patients, uncooperative patients. The absorption of drug is delayed, and some drugs are not absorbed at all, such as insulin. Do you know what is the difference between the topical and the transdermal route? Topically given drugs are applied onto the surface of the skin or mucous membrane, and they do not penetrate the skin layers. They stay in the epidermis for local action at the place where they are applied. For example, ointments. Transdermal drugs are applied on the surface of the skin, but they are absorbed across the layers of the skin into the bloodstream, from where they migrate to their site of action. For example, nitroglycerin patch is applied to the skin, but the drug is absorbed into the blood and reaches heart where it produces its effect.